Welcome to Team Renaissance's feature presentation of Kensingland, a Missed Opportunity. Do you agree with the choices Kensingland's government had made to date? What would you have done differently? The same? Team Renaissance disagrees with the choices that were finally selected by the Kensingland government. The initial concept created by Chen incorporated successes of other industrialized countries with similar economic indicators and ideals. However, after reviewing the draft, President Santow and his advisors believed that a single-payer system would be counterproductive to their previous decade's sustained economic growth. The final Santow-Chen plan embraced the existing multi-payer system. The insurance companies would be subject to increased governmental control, such as regulated pricing schedules and a requirement to shift to not-for-profit status. Throughout the process of the plan's development, the Nationalist Party, drug manufacturers, and insurers vehemently argued that the implementation of the plan would adversely affect the 87% of citizens that already have insurance. 5 years into the Santow-Chen plan, the president's goal for universal coverage exceeded his expectations. However, healthcare premiums increased by 36% and out-of-pocket expenses increased by 15%, demonstrating a negative impact on the disposable income of the 87% of population covered prior to the plan, as feared by the Nationalist Party. The Santow-Chen plan was primarily an insurance reform effort rather than a healthcare redesign effort. The plan did succeed in covering all of Kensingland's citizens. Team Renaissance agrees with many of the insurance reforms instituted, but overall disagrees with the Santow-Chen plan as a healthcare solution for the people of Kensingland. We agree with the changes to the insurance industry, such as shifting the organizations from for-profit to not-for-profit, establishing caps on deductibles and copays, establishing a system of risk equalization between insurance carriers, and defining a standard set of benefits. However, we think that the Kensingland government missed an opportunity to reform the delivery system by addressing quality of care through wellness promotion, and to address cost control by changing financial incentives. By continuing a fee-for-service reimbursement framework, hospital systems will continue to ask for increased budgets while competing for patients by marketing unproven technological interventions. Team Renaissance believes that the Santow administration should have instituted delivery system reforms such as primary care wellness teams. More health could have been brought to the population at a lower cost through the integration of behavioral medicine and by empowering the people with self-management through measures such as exercise and nutritional counseling. Additionally, Kensingland should have undertaken payment reform such as bundled payments for episodes of care and global fees for patients within healthcare regions. Team Renaissance believes that only by sharing financial risk with the delivery side of healthcare can incentives change from generating transactions to maintaining health. After implementation of the Santow-Chen plan, 109 health insurance companies remained. Although they were changed to not-for-profit organizations, each entity still wants to justify maintaining or increasing their yearly budgets. The large number of companies represents redundancy in the administration of healthcare and acts as a barrier to aligning strategy with other agencies within the Kensingland Office of Public Health. While the various insurers may be able to compete through incremental changes, they all face financial disincentives to assume the risk of transformative change. In the 5 years since the introduction of the plan, there's been a 79% increase in health expenditures against GDP. Further structural changes must be made to sustain healthcare in Kensingland. Would centralizing the healthcare system have been a better idea? Kensingland tried to find a balance between centralization and free market policies, but in the minds of Team Renaissance, they left things too laissez-faire, largely as a result of political pressure from the insurance lobby and the Nationalist Party. Centralization under the Santow-Chen plan is manifested by the Kensingland Payment Advisory Board, the sorts of delivery system reform and payment reform that we in Team Renaissance envision will require a commission with more authority to evaluate, regulate, and innovate rather than simply advise. Kensingland does not want to meet with the same escalating costs and disgruntled healthcare workforce seen in Germany, where the Institute for Quality and Efficiency tries to steer practice patterns primarily through centralized price referencing. Rather, centralized coordination of resources to address fundamental determinants of health would have a far greater impact. Like Singapore, Kensingland should look to unify strategy among the Office of Public Health and their departments overseeing education, housing, and social services. Are there ways to resolve the issues raised at the end of the case within the current Kensingland system? Will the major issues resolve themselves naturally over time, or do you think that more direct action, such as, will be required? 5 years into the Santao-Chen plan, the healthcare system remains fragmented, with increasing costs as transaction-based reimbursement continues. These problems will not resolve themselves, and political barriers exist to effecting change. The Kensing Payment Advisory Board, or the provincial governments, can try to institute reforms, such as a requirement for payers to provide a percentage of reimbursement through alternatives to fee-for-service. They can try providing grants to the insurance companies to offer performance-based bonuses and to providers for pilot studies of delivery system innovations, but again, these are only incremental changes. More transformative changes, such as those proposed earlier, or, as another example, for a universal electronic health record to assure information continuity for patients and to provide the metrics necessary to manage such a complex industry, will require a literal and figurative act of Congress. With little cooperation between the nationalist and people's parties, the chance of further alignment of Kensingland's healthcare resources and strategies is unlikely. In fact, a subfaction of one of the political parties, known as the CAFE Party, which stands for Can't Afford Federal Extortion, has adopted a mantra of never compromise. This is why Team Renaissance thinks President Santao should have instituted as much reform as possible when he had the opportunity. However, one powerful tool is available to the Kensing Office of Public Health to help mitigate concerns about increases in healthcare expenditure and program sustainability. Comparative effectiveness research is designed to inform healthcare decisions by providing evidence on the effectiveness, benefits, and harms of different treatment options, tests, procedures, or healthcare services. Comparative effectiveness research is a methodology for health systems and payers to address and answer questions such as, what is the most cost-effective means of contraception for reproductive-aged women? Or, what is the effectiveness of teeth sealants? There are two major ways this evidence is found. One, researchers review and synthesize the available evidence from existing studies. These are called systematic reviews. Two, researchers conduct new studies that generate evidence by comparing treatments, tests, procedures, or healthcare services. Thus, evidence is generated to guide clinical care and healthcare resource allocation. When it comes to healthcare, should ethical, social, or financial obligations be the priority? How to balance? Ethics should be the first priority for a country when considering health care for its people. Hubert Humphrey said, "The moral test of government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, those who are in the shadows of life, the sick, the needy, and the handicapped." Gandhi said, "A nation's greatness is measured by how it treats its weakest members." And Franklin Delano Roosevelt, when proposing a second Bill of Rights, stated, "Government should assure equality in the pursuit of happiness by guaranteeing specific human rights, employment with a living wage, food, clothing, and leisure, farmers' rights to a fair income, freedom from unfair competition and monopolies, housing, social security, education, and health care." Of course, money makes the world go round. Maximum fiscal value must be sought when distributing care. There is no room for government inefficiency, government or corporate corruption, or corporate profiteering if the most citizens are to receive the best care. To balance the financial, ethical, and social consequences in decision-making regarding healthcare, the four generally accepted medical ethics principles should be considered: autonomy, justice, beneficence, and non-maleficence. As Porter and Rye explain, these prima facie principles offer flexibility, represent a neutral frame of reference applicable to patients from different cultures and religions, and are independent of political doctrines. In an ideal national healthcare system, there should be balance between ethical, societal, and fiscal concerns. Through promoting a population-centered and wellness-driven healthcare marketplace, information, innovation, and best practices will permeate the delivery system. The healthcare system should rely on checks and balances between the public and private sectors and incorporate the best policies and practices generated from comparative effectiveness research.